Okay, good morning everybody. Welcome to this session on understanding your medication. Before we start, I'd just like to do a little show of hands. So if you could raise your hand if you had some medication to take this morning. Keep your hand up if you actually took your medication this morning.
I'm looking for mine now.
Okay.
I can't hear you now.
Okay.
Sorry.
Can you raise your hand if you had some medication to take this morning? Yep. And keep your hand up if you actually took your medication. Can you keep your hand up if you took it every single day this week? Yep. Anybody put their hand down there? No? And can you keep your hand up if you understand exactly why you have to take your medication? Not quite so sure. Okay. Hopefully this session will help you understand why medications are needed after stroke and look at some of the ideas of how you can actually improve how you manage your medication. Hi, do come in. Okay, do have a seat. A little bit about myself. I'm a nurse by training. I've worked in the NHS for nearly 20 years. I now work in research, and I have a special interest in stroke prevention. The other thing I perhaps should tell you is that I do sometimes talk quite fast, so if I'm going too fast, please do tell me, and I'll try to slow down. So we're going to be looking at why medication is important after stroke, some of the common medications that some of you may be on, why people have problems with their medication, what you can do to help yourself, and how you can get help if you need it. So why is medication important? Well, as Dale Webb alluded to in his talk earlier, which you may have heard, many strokes can now be treated with medication. Perhaps more importantly for the long term for you as stroke survivors, many strokes can also be prevented. But medications can also help with some problems that people may have after a stroke. So firstly, looking at the treatment of stroke. Good morning. There's some seats at the front here, sir. Okay. In the treatment of stroke, in the very acute phase, people can now have clot-busting drugs, thrombolysis. These can be given within the first 4.5 hours at a maximum, and they can actually reduce disability from stroke for some people.
Excuse me, Nav, have
yes.
you got a microphone? Because
I have got a microphone.
That's just for my camera.
Okay. I'll try and speak up a little. Okay. However, it's also very important in the very early stage after a stroke, when you're in the first few hours or days in hospital, that blood pressure is kept well under control, and also blood glucose. These things can also affect recovery after the stroke. So even people who don't have thrombolysis, because it's not suitable for them, they will still need medication adjusted. And if people have already been on medication, that might need to be changed in the short term when they're in hospital. And looking at prevention of stroke, the reason for this, the importance of this, is that if you've had a stroke already, you're at a higher risk than somebody else of having another stroke in the future. And it's estimated around 1/3 of people who've had a stroke will have another stroke within the next 5 years. That's an awful lot of people, as you can imagine. People may also go on to have heart attacks, other circulation problems, and these things also have similar risk factors to stroke, so they can be managed in the same sorts of ways in terms of preventing them. So if we look at 36,000 people in the UK who have a second stroke every year, it's estimated that if everybody had the very best preventive treatment that they can have, according to current day recommendations, we could prevent 4 in 5 of those second strokes. We could prevent 80% of them. And that would be a huge benefit if we could achieve all that.
Is that for major strokes, or is that for, would you include TIAs in there?
This is a second stroke. I think these figures don't include TIAs. Okay. Yeah, TIAs are also can happen after a full stroke, yeah. And there are 2 main planks of preventing strokes. The first is medication, which is obviously what we're talking about today. The second, which I don't want you to forget about, is lifestyle factors, and it's the usual suspects, things like diet, smoking. If you don't smoke, please don't start. If you do smoke, consider stopping. Taking some exercise and moderating your intake of alcohol, so not drinking too much. But we're talking about medication today, of course. There are several main types of medication that you may be prescribed after a stroke, and as I said, most of these aim to reduce the risk of having another stroke, so they're about preventing a stroke. However, there are some medications which do help with some of the after effects of a stroke, and I will talk a little bit about some of these. So in terms of reducing your risk of another stroke, the most important thing for the doctor and yourself to understand is what sort of a stroke have you had. And as you probably know, there are two sorts. There's strokes caused by a clot, an ischemic stroke. Sometimes this is due to a clot coming from the heart. It may be a clot from the carotid arteries. The second sort of stroke is a bleed, a hemorrhagic stroke, where there's a bleed within the brain. If the stroke is caused by a clot, there are three main things that you can do. You can lower your blood pressure, you can look at your cholesterol, and you can also thin the blood, as it were. For a bleed, obviously you don't want to thin the blood, but you do need to lower your blood pressure. So that's why it's very important to know what sort of stroke you have had, and then you and your doctor can actually plan what preventive medication is necessary. So I'm going to talk about mostly these three types of medication. I'll just talk a little bit about anticoagulants and diabetic medication. But the main types are blood pressure medication, statins, and antiplatelets. Very important to understand, though, that this is about prevention. It's not about cure. These medications will reduce your risk of another stroke. If you've already had a stroke, they don't help you recover from that stroke as such. And people sometimes don't necessarily have this explained to them properly. And they think, well, I've been taking these tablets for weeks and weeks, and I still can't walk properly. I've still got the effects of the stroke, so what's the point? And that wasn't the intention. It wasn't intended to help you recover from the stroke. No matter how well your blood pressure is controlled, it's not going to, unfortunately, undo the stroke that has already happened. So it's important, very important that people understand that. So blood pressure medication. High blood pressure is a very common problem in the population as a whole. But even if you haven't got high blood pressure as such, if you've had a stroke, you almost certainly need to have some medication to lower your blood pressure. It doesn't really matter if your blood pressure is already normal, because you've had a stroke, you're at risk of another one, and therefore you need to be on some medication for it. And there are 5 main types. I don't want to blind you with all the names, but there's 2 beginning with A, 1 beginning with B, 1 beginning with C, and 1 beginning with D in terms of the main groups. The ACE inhibitors, names like captopril, they always usually end in pril. The angiotensin II receptor blockers, big long name, usually end in losartan, a name like that. Beta blockers, names like atenolol, sotalol. Calcium channel blockers, and diuretics, water tablets by another name. Okay, so you might think, well, there's all these different medications. How on earth do they decide which one to start? It's relatively simple, sort of. If you're a little bit younger, and in this context, young means you're under the age of 55, the usual thing to start on is an ACE inhibitor, so a drug like captopril, or an angiotensin II receptor blocker, so a drug like losartan. If that isn't controlling the blood pressure well, then it may be necessary to add another type of blood pressure medication. If, on the other hand, you're older than 55, or you're somebody of African Caribbean origin, of whatever age you are, the best drugs to start on are calcium channel blockers, so maybe something like amlodipine, or a diuretic medication. And again, if that isn't enough by itself, then add another drug, something like an ACE inhibitor or an angiotensin II receptor blocker. So it varies which you start on, depending on who you are, how old you are. And some people do need 2 or 3 blood pressure medications to control things. Is anybody on blood pressure medication at the moment? Anybody on more than one drug? More than 2? 3? 2? Yep. 3. Any more than 3? Any advance? So it is not unusual for people to be on 2 or 3 different medications for the blood pressure. And also very important is to actually have your blood pressure checked. When we're recording the blood pressure, it's got those 2 numbers. The systolic is the high one and the diastolic is the lower one. And if you've had a stroke or a TIA, your target should be less than 130/80. If it's higher than that, then we need to look at it again and check that you're on the right medication. There is an exception to that. If you have carotid disease, so you have narrowing of the arteries in the neck on both sides, if we take your blood pressure below that target, below 130/80, then that might cause problems in terms of getting enough blood up to your brain, might give you dizzy spells and things like that. So you can have it running a little bit higher if you are one of those people who has carotid artery disease in your neck. But that's really the only exception. And it's important that you actually have it checked. I think there's a lot of people who are on blood pressure medication and it isn't checked as regularly as it might be. And although they're taking the tablets, they're not actually as effective as they might be. So statins are the next main class of drugs that people are often prescribed, also called lipid-lowering medication, lipid meaning fatty, meaning fats. And these act by reducing the level of cholesterol in the bloodstream. Cholesterol has a really bad press. It's made out to be a really bad thing. Actually, it's an essential chemical in your body. It's a building block of all sorts of things. But if you have too much of it in your bloodstream, then it is bad. Okay? They also act to stabilise the statins, to stabilise the fatty deposits in your blood vessels. So if your blood vessels are a bit furred up with fatty deposits, then it will help to stabilise those and help to reduce the risk of further clots and deposits forming. So who needs a statin? Well, if you've had an ischemic stroke, so it's been caused by a clot, pretty much everybody, if that's the case, needs to have a statin. There may be some people who it's medically not advised for them to take it, obviously. As with any drug, there are some people where there are contraindications and it's just not advisable. However, if you've had a stroke caused by a bleed, a hemorrhagic stroke, statins don't seem to help to reduce the risk, and there have been some very large trials looking at this, and they don't really help at all. If you do need to have a statin anyway because your cholesterol is very high, then that's obviously a reason to be on it. But just for stroke prevention, if you've had a bleed, it's not advisable. The statin drugs, all their names end with statin, so it's quite easy to recognise what they are. Simvastatin, atorvastatin, pravastatin are the main ones. And they all work in much the same way. They work on an enzyme in your liver that produces cholesterol and help to reduce its activity. It's very important to take them in the evening. If you take them another time of day, they won't work nearly as effectively because that's when your liver is actually doing the job of processing cholesterol. So it's very important to take them later on in the day. They do have side effects, and it's very common for people to report side effects. An awful lot of people are on statins worldwide. It's probably one of the most commonly prescribed medications. Most common problems are muscle aching and digestive problems. Some people do have more serious problems, but the important thing with side effects, if you think you're having side effects from any medication whatsoever, tell your doctor. Don't just say, oh, I'm getting side effects, I better stop taking it. Do tell your doctor. With the statins, it may be that you get side effects with one particular statin drug, but if you switch to a different one, it might suit you better. So there are sometimes ways around it. And then, excuse me, antiplatelet drugs, sometimes called antithrombotic drugs, thrombus meaning clot. And people sometimes say these make the blood less sticky, and that isn't quite true. They actually, as the name implies, they act on the platelets in your bloodstream, which are very small particles which are the start of the clotting process. So if you inhibit their ability to clump together, then you will make it less likely that clots form in your bloodstream. Okay? And antiplatelet drugs, the most common, the best known one perhaps is aspirin, the old favourite. But the recommended treatment now in the stroke guidelines is actually clopidogrel as the first drug to use. And if that isn't suitable, if somebody has bad side effects from it, something like that, then aspirin and dipyridamole together give about the same sort of effect. Until fairly recently, the recommendation was aspirin and dipyridamole. It's been changed, I think, in the last year or two. Don't quote me on that, but it's fairly recently, to clopidogrel being the recommended first treatment, simply because clopidogrel is now not under patent, so it's much cheaper than it used to be, and in terms of the cost, it's the cheapest option to use, and they're both about as effective as each other, these two things to have. Obviously, taking aspirin and dipyridamole, you've got two medications instead of one with the clopidogrel. Okay? The other thing I'm just going to talk about a little bit is anticoagulants. And this obviously doesn't apply to quite so many people, but this is an important part of prevention if you've had a stroke caused by a clot coming from the heart. And the most usual cause of this is an abnormal heart rhythm, atrial fibrillation, AF it's sometimes called. And if you look at the little picture on the left-hand side, you can see the top, you've got a quite normal heart rhythm there, that's an ECG trace, and it's nice and regular. If you see those little peaks, they're nice and regular. The bottom one, you can see they're not so regular, and that's atrial fibrillation. And because the atria, which are the top chambers of your heart, if they're not contracting properly, which is what happens in AF, they're not pumping properly, they're just fibrillating like that. People sometimes say it's like a bag of worms. They don't empty properly, and therefore clots can form within those chambers of the heart, and then those clots can go up to the brain or elsewhere in the body and cause a major stroke. So what you need if you have atrial fibrillation is you need medication to slow down the clotting process. And there's two types. There's the old favourite warfarin, and then there's the new kids on the block, which are the main ones are dabigatran, rivaroxaban, and apixaban. And these have only been out for a relatively short period of time. Warfarin has been in use for about 50 years, I think. So there are pros and cons to both of these. Warfarin, it's very much tried and tested. There's a lot of experience with using warfarin. A lot of people have been on it for many, many years. And if it's managed well, it is an effective drug. However, you do need to have regular blood tests. Is anybody on warfarin at the moment? Yeah. Regular blood tests, yeah, which is a nuisance. And also the dosage sometimes has to change. And so it's quite complicated to take. You know, 1 week you might be on one dose, and then you have a blood test, and then it has to change to a slightly different dose. So it's a little bit tricky to manage. So as I say, it's effective if it's managed well, but that's quite a big if. A lot of people are not within their target range on the warfarin a lot of the time. And if you're not within the target range, then it's not going to be effective. The other thing about warfarin is that if you do need to reverse the action, for example, if you, God forbid, have a major accident or you need emergency surgery, something like that, it can be reversed quite easily. The new medications, they do have their advantages. You don't need the regular blood tests, which is a great boon for people who, most people don't like having blood tests. And the dosage is the same no matter what, so it's the same dose every day. They're just as effective as warfarin, but they do have side effects for some people, and it is difficult to reverse their action. There are some new treatments coming on stream at the moment to reverse that, but if you do need an emergency surgical procedure, something like that, then it is problematic if you're on one of the new anticoagulants. So I would say if somebody's on warfarin and they're managing it well, then stick with what you know, because it's working. If it's more problematic, then certainly the new drugs are something to consider. I'll just mention diabetic medication as well, because stroke and diabetes often go hand in hand. Stroke is quite a bit more common in people who have diabetes, and indeed it's not unusual for somebody to come into hospital having had a stroke, and this is the first they knew that they had diabetes when they have all the associated tests that go along with that. And people may be on insulin, and they may be on tablets like metformin, for example. And it's important, again, for that to be well managed.
Could I just ask, is the medication for SVT, would that be the same as for atrial fibrillation?
Oh, I couldn't tell you that confidently.
Right.
You'd be on beta blockers, I think, yeah. You can be on beta blockers for
Is it
atrial fibrillation as well.
It's been explained to me as being a similar sort of problem.
Yes, yeah. It's a somewhat less common arrhythmia, I guess, but atrial fibrillation is the main one.
But it's not an arrhythmia that causes stroke, so it's not one that we prophylax against stroke. We're prophylaxing against the inconvenience and unpleasantness of having a heart that's racing at 150.
Yes, yes.
So you're
SVT
slowing
is
down a beta blocker or drugs like verapamil.
Right.
So the same sort of drugs that you use for blood pressure control, but
Yes.
we're using them to slow the heart.
yes, thank you. Yeah.
Thank you.
SVT is a tachycardia where the heart is racing, and so that gives people symptoms which are unpleasant, as Professor Barthers has mentioned.
Yes, I know.
Yeah. The thing about atrial fibrillation is that often people don't have any symptoms whatsoever unless you actually check their pulse. And I think the Stroke Association currently have a campaign about people actually being screened for atrial fibrillation. It's very common in people over 65 to have atrial fibrillation and not know it. So the important thing with atrial fibrillation isn't so much about managing symptoms, because people often don't have any symptoms. It's about managing the risk of stroke. Yeah. I just want to talk a little bit about some medication for the effects of stroke. Now, I said earlier that we can't give medication to treat the stroke. We can't reverse the stroke itself after that very early period when you might have thrombolysis. But if you do have long-term problems after a stroke, then there are some medications which can help. And perhaps the more common of these are pain, depression and epilepsy. So pain, first of all. Probably about half of people who've had a stroke do have some degree of pain, and this can be pain in the shoulder on the affected side, yeah, a little nod of recognition there from the gentleman at the front, or sometimes people just have more generalised pain throughout the body, and it can be quite difficult to manage. The possible solutions are simple painkillers, things like paracetamol, the stronger drugs like codeine, anti-inflammatory drugs, the ibuprofen, that sort of class of drugs. Other medications, anticonvulsant therapy, anticonvulsant drugs can actually help if it's nerve pain. But other treatments like physiotherapy and relaxation can also be beneficial in conjunction with the medication. So it isn't just about taking the right tablets for many people. And depression, again, is a very common problem after stroke. About 1/3 of stroke survivors do have some degree of depression. For some people, this is relatively mild and it's something that they can get through. But some people do need more specialised treatment and support. And antidepressant medication can obviously help some people with this. But talking therapies are also very important to help with depression. And then epilepsy. About 1 person in 20 will have a fit after their stroke, a seizure or fit. It's not so much a problem if it's just a one-off event, which sometimes happens around the time of the stroke itself. Some people do have more than one seizure, and if it's an ongoing problem, then clearly you need to have medication to prevent further seizures in the future. And I've just listed some of the many drugs that can be used here. Okay. The other thing to remember is, of course, that many people who are stroke survivors will have other medical problems as well, because stroke tends to be a disease of a condition of later life. As we get older, all sorts of other things happen to us medically, And people might have arthritis, for example, they might have chest problems, that sort of thing. So you may need medication for all these other additional unrelated problems as well. So this means one heck of a lot of tablets. If we actually look at whether people take the medication or not, it's a difficult thing to measure because you've got to look at whether people are taking them at all over a period of time, and then whether they're taking the medication as it is prescribed. But the accepted figure, and this is the World Health Organization, for any condition at all, the adherence, which is what it's called, to long-term medications is about 50%. So if you were to look at all the prescriptions worldwide for long-term conditions, about half of them aren't taken as they should be. Some people take everything absolutely spot on. Some people don't manage at all well. Lots of people are somewhere in the middle. So it's not just a problem with stroke, but there are some specific problems around stroke. So problems can arise because of prescribing. If you were never started on the right medication, clearly you're not going to be able to take it. And it's very important that people actually go home from hospital with the correct medication that they should be on. Secondly, there can be problems with people continuing their medications. So it may be that a doctor will stop a medication that perhaps should have been continued, or the stroke survivor themselves, perhaps they're getting side effects, or they just don't realise that they're supposed to continue on a medication long term, and they just stop taking them. So if somebody goes home on their medication and they've got, say, a 2-week supply, if that 2-week supply finishes and they don't realise that they need to continue, then they're going to stop. And then there are also problems with people taking their medications from day to day. So there are lots of ways in which things can go wrong. So if you would, at your tables, if somebody could volunteer just to jot down the discussion. There's some really interesting ideas, and most of which I think I've possibly covered in the next slides, but some of which I hadn't. So thank you for that. As you mentioned, there are practical problems that people have. Fiddly packets, the bottles are difficult to open. If you have eyesight problems, you can't read the labels in the first place or see what you're meant to be taking. Some people have swallowing problems after a stroke, and that obviously can make it very difficult, particularly with the larger tablets. And just getting the darn prescriptions from the doctor, going to the, getting the order, going to the pharmacy, all the rest of it can be difficult, especially if you have mobility problems, of course. And then there are the more subtle problems which people alluded to, which are perhaps less obvious. Problems with remembering, if you have memory problems. If you have problems with understanding, with cognitive difficulties after the stroke, understanding what you're meant to be taking. And if people have communication problems, if they have aphasia, it may be difficult to take in to understand the information that's being given and to communicate about any problems that you're having. And there are other reasons why people don't necessarily take the medication as expected. Some people don't realise they needed to continue. A lot of people worry about being on tablets. I don't think there's anybody in the world who really likes taking tablets. And it's perhaps a problem with people who've previously been very healthy, maybe younger people who've then had a stroke, that it's just not something that they were ever expecting to do at this point in their life. That being on tablets is something that they don't like at all. And it isn't so much a problem in this country because we do have the NHS, and there are prescription payment schemes, so you can spread the cost of your prescriptions, but there can be a cost issue, of course, with lots and lots of prescriptions. So things that help is understanding why the medication is important, and the table at the back, you mentioned that knowing that if you don't take these medications, you're more likely to have another stroke is a big, big motivator, isn't it? Getting into a good routine and keeping your medications in the same place is really important. Also keeping it simple. If the medications can be taken at the same time every day, just once a day, then that's great. Sometimes you need to be on things twice a day. For example, most drugs are better taken in the morning, whereas statins are at night time, but keep it as simple as it's possible to keep it, really. And then looking at those practical problems like the fiddly boxes and things like that. And as we mentioned, the people who can help in the hospital setting, whether it's on the stroke ward or when you come back to clinic, you can get advice from the pharmacist, from the doctor, or from the nurse in clinic. And of course, if you've got another condition, then other doctors may be able to help as well. And I think this is sometimes where the problem happens, when people have lots of different medical problems and they're seeing different specialists and things keep getting added and they get in a terrible muddle. And back at home, people have mentioned the help that the pharmacist can give, and GP and the staff at the surgery as well, and care workers if you have care support. Medicines review, I think one of the tables mentioned this. The pharmacist can do this for you if you're a regular customer of theirs, and they can check that you're on the right things, that they don't affect each other, because obviously some drugs affect other drugs, and they can help you understand what you're meant to be taking and help you organise what you're doing. And your GP can also help in terms of that as well. Getting prescriptions, I would say always ask for your repeat prescriptions in plenty of time. So if you get a month's supply at a time, when you get them, make a note on the calendar when you next need to ask for them, so you don't run out. Pharmacies can help an awful lot with repeat prescriptions, and people have mentioned ordering them electronically and so on. They can also collect the prescription from the GP, so all you have to do is make one trip to the pharmacy instead of another trip to contacting the GP as well. And of course they do deliver if you need that service as well. The other group of people, as you mentioned, family and friends, carers, and this can be help to get prescriptions, helping to organise the medicines, and just reminding, which you might want to call nagging, but reminding is possibly a more polite term, but can play a very important part if it's something that you're having difficulties with. Other places, as you said, the Stroke Association, and I've just put another couple of websites which are, there's an awful lot of misinformation on the internet, but these are quite reliable websites about healthcare generally. Obviously the NHS website and patient.co.uk. So top tips, get into a routine that's right for you. What works for you might not work for somebody else, but if it works for you, then that's good. If you're not sure what you should be taking, ask your doctor, and make sure you know what the medicines are for. Have the checkups that you need to have, your blood pressure, any blood tests that you might need to do with your medication. And if you need some practical advice, then the pharmacist is a very good person to ask. Okay, it's been an absolute pleasure, ladies and gentlemen. Thank you very much.